All right. I know everybody's starting to log in now. I'd like to welcome everybody. As you guys know, my name is Ginger. I'm the Executive Director of Connectionology Seminars of America, and we are very excited to have you with us today. I am excited myself because we have Tina here with us. Jessica is going to be helping us moderate as well, but Tina is an amazing attorney out of California. Jessica's going to let you know all the great details about her as well, but you are in for a treat, and you guys are going to learn so much today. I hope that you will ask questions. We encourage that. You can please put those in the chat box or the Q&A box so that way Jessica can keep an eye on them. And then just know that later on in this webinar, you're going to hear from our amazing partners over at HMR, Fox AE, and OnPoint. So let's go ahead and get started. We've got a lot that we're going to be talking about, and there's a lot that you guys are going to learn as well. As you guys might know, we are thrilled to have Jessica back with us. She is a great attorney out of the law firm with John Romano Law Group in West Palm Beach. She is graduated from the Florida Atlantic University in Boca Raton, Florida, with a Bachelor of Business Administration. And she also attended Berry University School of Law in Orlando, Florida, where she graduated early and she got her Juris Doctorate degree in December of 2013. But for those who don't know, prior to joining the Romano Law Group, she served as an assistant state attorney where she gained a lot of experience in trial and litigation. And then she joined the private sector working for a prominent civil litigation defense firm, and that handled a ton of complex litigation matters. So she focuses a lot of her practice working on representing plaintiffs who've been involved in a lot of catastrophic injury matters, as well as those cases that include wrongful death, auto negligence, medical malpractice, as well as premises liability and product liability. But outside of the litigation practice, she's very involved in the local community as well as in the state associations as well. But she serves as a chair for the Palm Beach County Justice Bar Association Lawyers for Literacy Committee. She also serves as the director of the Palm Beach County Chapter of Florida Association for Women's Lawyer Sponsorship Committee. And then also she is a past president, I believe, of the Lake Worth High School Alumni Foundation, as well as sitting on the board of the Lake Worth High Scholar for Dollars, which is a nonprofit foundation that supports a lot of academic success in the community. So you guys, we are really, really excited to have Jessica with us, and she will be introducing Tina, and I hope you guys have a great webinar.
Hi, and welcome everyone. I'm so excited to be here, and I'm excited to introduce Tina Eshghieh, who is a partner and head of the Workers' Compensation Litigation Department at Arash Law. She specializes in litigating complex and catastrophic injury cases on behalf of injured workers throughout California. She has extensive experience in cases involving traumatic brain injuries and spinal cord injuries, and has recovered well over $50 million on behalf of catastrophically injured workers. Prior to entering the field of catastrophic workers' compensation, Ms. Eshghieh was an attorney at a prominent class action litigation firm in Los Angeles, where she litigated complex wage and hour and consumer class actions in state and federal court. She now applies her experience to negotiate high-stakes settlements for her catastrophically injured clients. So welcome, Ms. Eshghieh, and I'm glad to have you here, and I will turn it over to you now. Thank you.
Thank you so much, Jessica, for having me, and Ginger as well. I'm very excited to be here and share with you, my background in brain injury litigation and bring some perspective from the workers' comp arena as to how we apply some of the medical workup that we do in our cases to personal injury matters as well, because there's a lot of interplay involved. And when it comes to workers' comp, some attorneys believe that we may actually dive even deeper into the medicine than our personal injury counterparts. So there's something to be learned from our background in it. So I'm excited to be here, and I'm going to go ahead and start by sharing my screen so you can see the slides as we go forward. And then if anybody wants access to them, please feel free to reach out to me after the webinar, and I'll be happy to share them. So I just want to make sure, Jessica, on your end, are you seeing the slides?
Yeah, once you start it, there you go.
Okay, there we go. Okay. So mild traumatic brain injury, we're going to talk about how to spot the mild TBI from the start of your intake and then the medical workup that's involved. So for those that aren't familiar with TBI, CDC defines it as a disruption in the normal function of the brain that can be caused by a bump, a blow, a jolt to the head, or a penetrating head injury. So what that really means when we break it down is that any sort of trauma to the head that causes some sort of disruption in your status, whether it's physical, emotional, cognitive, it all can be defined as a traumatic brain injury. It's not just a physical injury, it's all encompassing. What I like to say is that the brain is really the CPU of, our human computers. And depending on where it's hit, you can see it manifest into all sorts of different symptomology. No TBI is the same. They're all unique. And there's so much that you can dive into when you're talking about diagnosing or spotting it, as well as in treating it. So just to give you some perspective, in the United States, there's about 1 TBI every 17 seconds. That data is actually almost 10 years old at this point. So I would imagine that it's even more than that. Males are 3 times more common, often dying from TBI than females. And at this point, about 5.5 million live with TBI-related disability nationally. So when we talk about causes of TBI, in the workers' comp arena, I deal with a lot of construction accidents, auto accidents, but there's other ways that you can see TBIs pop up. You'll find them a lot of times in falls, from just a trip and fall to falling from a height. You'll see a lot of times people being struck by objects. Not only will you have, things in construction zones where people have things falling on them from a height, but I've seen accidents involving, people that are working, like under a car, a mechanic, and they get hit with a wrench in the face. You wouldn't imagine it's going to leave any sort of permanent damage, but you'll see people that are having symptoms manifest for years to come. And then violent acts also sometimes we'll see especially in the work arena, and in the criminal arena, you may encounter, assault and battery. So types of brain injury. We have everything from what we call a concussion or mild TBI, which is when you sustain an injury to the brain where traditionally you're not seeing it necessarily show up on a CT scan or an MRI, and there may not be even a loss of consciousness, but there is some sort of change in status following this blow to a head. And then you're dealing with ones that go to more severe, from moderate to severe TBI involving blood loss, blood in the brain. So you're seeing it show up on a CT scan, MRI. There's some sort of hematoma. We also have anoxic or hypoxic brain injuries. A lot of times you'll have complex orthopedic injuries take place where there is either somebody that's, having an extreme amount of blood loss or a lack of oxygen to the brain, and that is causing some sort of brain damage and brain injury as a result. So what I would say to attorneys that are doing intakes involving complex orthopedic injuries or injuries where somebody may have gone in for emergency surgery, do a comprehensive TBI checklist, even on those cases, because you may see once you get records that there was some degree of anoxia or hypoxia involved, and that lack of oxygen to the brain may have caused damage and requires, there to be appropriate workup. Then you have the coup or contra coup injuries. Those we see a lot in auto accidents. Basically, it's involving, somebody that may have an injury to the head where it's not typical where you see them actually hit something or something hit them, but really it's this jostling of the head and the brain within the skull. That causes some form of micro tear because you're having, this soft, mushy brain, and it's being hit against the skull when you have an accident, where you see this whiplash injuries. And that hit both can cause, frontal lobe damage, but also to the back, depending on how severe the mechanism of injury is. Then we have some of the more typical penetrating brain injuries where you see somebody have a skull fracture, whether it's from a blow to the head or sometimes like gunshot wounds, stabbings, things like that, where there's actually penetration, those can result in very severe brain injuries. And then in addition to, or kind of a spinoff of the coup or contra coup injuries, you'll see diffuse axonal injury. Those are shearing injuries where there is actual widespread damage to the brain because of the severity of the blow. And it can cause, encephalomalacia. You can see it show up and find objective findings in scans that follow.
Tina, we have a couple of questions if you want to take a moment. I think
Sure.
kind of let you finish that slide. The first one says, do you have a good screening questionnaire for for a TBI?
Absolutely. So I have some that are contained in the slides that are going to follow, but in addition to that, I have some that are a little bit more comprehensive. So if you reach out to me, I have my email at the end of the slides. I can go ahead and send you those checklists, and they're very helpful. A lot of attorneys have told me they'll just give the checklist itself to the client and have them fill it out, and it sheds light on a lot of what they're experiencing.
Okay, and then there's another one that says, can you address the auto crash case, for example, a rear end collision with a violent whiplash and no penetrating injury in terms of provability?
Okay, so in terms of provability, depending on what specifically you're asking, with those coup or contra coup injuries involving whiplash, you may actually see objective findings of it on a scan, depending on how severe it is. But we're going to get into a little bit more detail about different ways to prove up your brain injury when you're seeing these mild brain injuries that are not necessarily showing up on a scan. But whether it's mild, moderate, or severe, the workup is going to be very similar. And how you prove it in terms of, the mechanism of injury, you may need to get like accident recon involved, but you can find objective data that will prove up that there is actual brain damage, and we're going to get into that a little bit. So with regards to types of brain injuries, just to go a little bit more into detail, because a lot of times you will see on initial hospital reports open brain injury versus closed brain injury and not really understand why they're characterizing it as such. So closed brain injury, very simply put, it's without the skull being broken or penetrated, the brain has not been exposed. Okay, so when you have those auto accident cases we're talking about, where there's coup or contra coup injury, rapid movement of the head backwards and forwards, that may cause a closed brain injury. When you have an open brain injury, it's penetrating. So it can be focal or diffuse, meaning that it's isolated to one area. Let's say if it's a gunshot wound or a stabbing, or if something falls and penetrates and causes specific isolated injury, or it can be more widespread, depending on how large the object is or what kind of trauma the person sustained. So we also have a different way of characterizing brain injury, which is by primary injury or secondary. So primary is more what you would expect. It's, when the mechanical force occurs and causes that accident. Okay, so you have a blow to the head, or you have something fall on the head, you have someone fall and hit their head. But a secondary injury it's not, what we typically think of. It may be more delayed. That may be something like those anoxic or hypoxic injuries, but it also may be sometimes you'll find situations where somebody will sustain a stroke secondary to, a catastrophic injury. Or you may have somebody that has, an aneurysm that bursts during the mechanism of injury. So there may be a secondary brain injury involved. So when you talk about main mechanisms of a primary injury, we just kind of got into like the object striking the head or the brain striking the inside of the skull. That's primary. But in addition to that, when you dive deeper into the primary, it breaks down even further. That primary force can cause an intracranial hematoma, diffuse vascular injury, injury to the cranial nerves or the pituitary stalk. And we'll see things regarding pituitary injury that's involved, secondary to the primary brain injury. So going more into the medicine, a lot of times we will see, medical records come in, and a lot of attorneys will say, I don't see anywhere it's saying that the person has a traumatic brain injury. they don't call it brain injury. I don't see anything like that, but the client is experiencing all the symptoms you're talking about. So in those situations, it's important to start looking more into the details, because a lot of times hospital records will talk about the hematoma or hemorrhage, but they won't classify it as a closed head injury or traumatic brain injury. But it's just still the same thing. It's all under that umbrella. So you want to look for those details. Just to give you a little bit more info as to how we break these down. Hematomas are characterized as the follows. So you have epidural hematomas. These occur when blood accumulates between the skull and the dura mater, that thick membrane that covers the brain, okay? And they typically occur when a skull fracture tears the underlying blood vessels, okay? So with that said, those are the ones that are probably most often seen and most typically are less severe than the subdural or subarachnoid hemorrhage, okay? Subdural hematomas occur when the blood vessel in the space between the skull and the brain, but the subdural space, so it's a little bit deeper, is damaged. So the blood escapes the blood vessels, leading to formation of a clot, a hematoma, and it places pressure on the brain and causes damage. And then you have subarachnoid hemorrhaging. That's when there's bleeding in the space between the brain and the tissue that covers the brain. It's the deepest part. And this is called the subarachnoid space. So I have some photographs. If you Google it, you will find so many illustrations that can show you not only, something like this, but more of an actual like imaging and scans and where you can see it. So you can become a little bit more familiar with how to identify it rather than an illustration like this. So TBI at intake, for the person that was asking me for a checklist, this is some of the more general stuff that you'll see, but we can dive a little bit deeper into it as we go along. So when you have a client that's telling you after an accident, and they may not even say that they got a blow to a head, because again, we see a lot of these injuries where the person may have, had this whiplash injury, or sometimes they will not even remember the mechanism of injury. And in that situation, they may not have even remembered that they had a hit to the head. They may have lost consciousness and not even recall that the reason was because of the blow to the head. But if you're hearing a client tell you, I'm having memory problems, I'm having difficulty concentrating, I'm having difficulty with attention at work, I'm not able to stay on task, or I'm getting very agitated and my wife is saying I'm not acting like my former self, I'm feeling paranoid. Some of this stuff may, at first glance, especially if they're not telling you right off the bat that they've had a head injury, you may not really quickly connect the dots, but you are going to want to dive deeper, because these are very, very prevalent in mild, moderate, and severe brain injury. And it's, what we need to do in terms of putting together the pieces. We need to start with that initial intake and asking all these questions. A lot of times people start to become withdrawn or socially isolated. It's not only because of the psychological factors involved, but also a lot of times people after brain injury feel very hyperstimulated. They go out into public, and the sounds that before were kind of, able to just be present and not bother them, now they're experiencing it all at once and not able to, what we call, kind of field it out, okay? Mood swings, sensitivity to light. A lot of times they'll say that when they go out during the day, they feel like they cannot leave without sunglasses. It's just too much to bear. Or even inside during intake, a lot of times I will have the client tell me like, oh, can you dim the lights? It's bothering me. It's giving me a headache. Ringing in the ears. A lot of times they won't notice it during the day, but you want to dive deeper. You want to say, at night when you're trying to go to sleep, are you experiencing ringing in the ears? I'll even see some clients that are not as sophisticated or not as familiar not say it's ringing. They'll say, oh, I don't hear ringing in the ears, but I hear like I'm under the ocean, or I hear hissing. So we have to be good about giving them more options as to how to describe what they're feeling. Because a lot of times I will have people get these checklists and they will just give it to the client. And if the client doesn't fill out much, but even they have had like a witnessed head injury, they'll let it go. They're like, oh, they don't have any of these symptoms. It must not be a TBI. You want to get more into it. One example that I hear a lot is a client will tell me they're not experiencing any dizziness or balance issues. However, I tell them, okay, go home and take a shower and close your eyes and try to wash your hair and tell me what happens. And they call and they say, when I try to close my eyes, I cannot keep balance in the shower. And I never even realized it until you told me that. You have to become kind of a detective at these times and give them scenarios, give them a lot of information in terms of examples to help them figure things out. Because a lot of times with brain injury, people are lacking insight into their own deficits, or they're finding themselves writing things off. Oh, I was on medication and coming out of the hospital, so all this stuff is medication related. Or, oh, I'm in a lot of pain, so that's causing all this other stuff. So you're going to have to overcome that to some degree and help them to not only give you the information you need to identify the brain injury, but also help them to not be their own worst enemy in terms of, being in denial as to what is exactly going on.
Tina, we have a couple more questions.
Sure.
I think kind of pertaining to this slide. So the first one is, how do you know that these symptoms weren't caused by injury to the pituitary gland?
So you don't, not necessarily. What you're going to want to do, and I have some slides coming up that will discuss it further, that you will potentially want to have a referral to an endocrinologist that can do lab work specifically to find out if there are some, secondary injuries as a result of the head trauma that may cause growth hormone deficiency, issues with testosterone, all sorts of hormonal imbalances that could be secondary to the brain injury. And that is part of a brain injury. Again, kind of like what I said in the beginning, it's the CPU of our body, right? So a injury to the brain can cause injury to your balance system, to your hormones, to everything, essentially. So it could be a pituitary injury, but that is in conjunction with the brain injury.
All right. And then if someone mentions a ringing in the ears, what type of specialist do you think is best for them to see? An ENT?
That's a great question. ENT is a great place to start. A lot of times I will also refer them over to an audiologist. There are audiologists that do a lot in terms of treatment for ringing in the ear tinnitus. There's devices now that the client can use to help them, to condition them to be less affected by the ringing in the ears. And they are costly therapies that should be taken into consideration in the workup. So ENT or audiologist.
Okay, thank you. And then what is the connection or overlap between TBI and vestibular dysfunction?
Good question. So vestibular dysfunction can be a byproduct of TBI. Your balance system can be impacted a lot, depending on if it's peripheral or central. Sometimes one way that I've heard people describe it, it's the crystals are dislodged and can cause a disbalance. Like our level of equilibrium can be impacted or disrupted. There are tests that can be done, and we'll have some more detailed information on that in the slides that are coming up, that can identify vestibular dysfunction and also provide objective information or objective data that can prove up your brain injury. So again, just like some of the other things that can be experiencing as a byproduct, vestibular dysfunction is definitely one of them.
And that's all we have right now.
Okay, so going further into the symptoms: aggressiveness, decreased sexual activity, slow reaction time, blurred or double vision. A lot of times we will have clients that are saying, oh, my vision's not blurry, but when I'm driving now, I feel like my peripheral vision is off. Or they'll say, when I'm trying to read a book or the newspaper, my eye keeps getting off center and I have to go reread the same line again. I'm getting confused. So you want to talk about each one of these symptoms in a little bit more detail. As you become more familiar with doing intakes with TBIs, you will develop your own examples. Like one that I encounter over and over, and now I ask almost every client is, do you find yourself leaving the stove on when you are trying to cook? Do you walk out the door and forget to lock it? These are kind of examples that I've heard so many times over the last years that now it becomes part of my arsenal of things to ask during that initial intake. Another thing is word finding difficulty. That's a big one that can help you to weed out if they are having memory issues or different or other issues that may be related to brain injury. So I will always tell the client, do you feel like you have, when you're talking, words are on the tip of your tongue, but you can't bring it to the forefront? If I say it like that, rather than saying, are you having word finding difficulty, I'll get a lot more, positive feedback or get more information as to what I'm looking for, because they'll say, yeah, the other day I was trying to refer to my daughter and her name just could not come out. I couldn't, recall it to say it. And I know who my daughter is. I know her name. So you want to get into examples. You want to elaborate on these symptoms and not just talk about a checklist, and give it to them and say, okay, that's it, because you will be missing out on vital information. So just to go a little bit more into detail and help in terms of what you will typically see with different types of head injury, I gave it to you in terms of a checklist here as well. So for frontal lobe injuries involving, impact to the forehead, you're going to see more changes in behavior, issues with motor skills or spatial reasoning, attention deficits, difficulty sequencing, perseveration, personality changes, difficulty with problem solving, difficulty with verbal expression, loss of empathy. You'll a lot of times we'll see the most behavioral brain injuries involving frontal lobe injury. So the clients that I see struggle the most in their interpersonal relationships, the ones that I see the most complaints coming in from the spouse saying this person has changed, this is not the person I knew before, is involving a lot of times frontal lobe injuries. And the other good thing to take into account is that when you have impact to a certain part of the brain, and you potentially even have objective data via, a DT-MRI or other types of scans, let's say, it is a wonderful tool to take that information that you have and correlate it with what a neuropsychologist can provide you. Because a lot of times a neuropsychologist will be able to give you data as to specific dysfunctions cognitively or psychologically that their patient is experiencing. And when it corresponds to the part of the brain that's actually been impacted, that is an amazing thing to be able to illustrate to the carrier, to the defense attorney when you're talking about making a demand that, what, I have somebody that this is where the impact was and everything's lining up. This makes sense.
Hey, Tina, just going back before you started talking about the frontal lobe. So there was a question. I don't know if he's trying to be funny, but it's a valid question anyway. So he says, I leave the stove on and I leave the door unlocked. Isn't that just old age? So I would add to that, how would you differentiate? How would you determine if it's due to age or if it's due to a mild traumatic brain injury?
That is a good question. And I could see a defense attorney definitely asking me that or saying that when we're in mediation. Look, none of this stuff is black and white. Actually, I've had many times defense attorneys say this is all smoke and mirrors. But you have to paint a picture and you have to have the evidence to back it up. When we're talking about asking these questions, it's in the arena of an intake. So you're talking to a client, you're saying, what's changed? If this person, especially is the type that says, I pride myself on being, on time, I have a very good memory, I know, I keep everything organized, or whatever they're describing, they're saying this is something that's changed. Because remember, we're going back to that initial definition, there's a change in status. Then that's something that you need to take into consideration. This person is saying, like, I've never lost my phone or my wallet or anything in the last 10 years. And a matter of 2 months since my accident, I've had to replace my phone or go and get a new phone twice because I lost it. Then something is different. There's a change in status. This is outside of the norm. So same thing with somebody that has left the stove on and, caused a fire in their kitchen. Yeah, it could happen to anybody. I've left my tea kettle on before and come home at the end of the night and I'm like, oh crap. But if I'm doing it and then I'm also losing my keys in the same week and I'm also leaving the front door unlocked, or something's happening where now people are starting to say in the household, what's up with you? Why are you being so absent-minded? Why are you such a mess? that's when we have to actually start taking a deeper look into, could this be TBI? So although, yeah, once in a while it happens, if you're having it happen more than, once in a while, then I would say it's not just old age. You maybe should go get checked out.
All right, and then there is another question. It says, do ERs commonly miss minor TBIs, and is there any literature on that you can share?
Absolutely. They're very often missed, especially involving cases with some sort of secondary injury or concurrent injury. So when we have clients come in and they've had, some sort of orthopedic overlay, so they've fallen from a height and they've fractured a leg, especially when the injury is more catastrophic or more severe. When the person comes into the ER, the emergency room doctors are trying to deal with the trauma, whatever is, most evident right when the patient is brought in. So that may be that fracture, or it may be, something else. And during that time, all the focus is on that. And it may be where not only the doctor is not taking a look and diagnosing or commenting on the head, but the patient is also focused on that pain center. So they're not really thinking about the head or bringing it up. So it's often missed in that way. Additionally, one thing that I would say is a big tip that everyone should take into consideration. Sometimes you'll see no documentation anywhere in the hospital records of head injury. No discussion of symptoms, no discussion of the trauma, but you will see that a head CT was done. And that is a big indicator that there was some head involvement or concern of head involvement that caused the doctor to request a head CT. And I will often cite to that, even if the CT is clean, which 99% of the time it will be, unless you're looking at a more severe brain injury. But the fact that they did a head CT initially means that there was some complaint or some concern about trauma to the head, and they wanted to rule out a more serious issue that could have required surgical intervention or need for more intensive monitoring. And with that, I will always include that documentation, even though it's a clean CT, to say, look, from the day he was brought into that hospital, there has been a CT scan conducted because there was a concern about damage to the head. And that will be maybe all you will see. But don't let that discourage you, because the fact that they did that while they were treating the patient means that there's something to be concerned about and something to look a little bit deeper into now that the dust is settled with treating everything else.
All right, and then another question did come in. Sorry, I know I said that was the last one, but the question is, can you use normative scientific surveys on the average memory functioning for patients like your client in combination with recent change in status? Surveys and data like the Halstead-Rayton neuropsychological battery and the Wechsler memory scale.
Okay, so can you use it? Yes, so neuropsychologists will often use those scales and testing and compare the results of that specific client's test to normative data. So that is how neuropsychologists will provide you with information as to how that person is performing and where the deficits are. So they're taking normative data and they're lining that patient up to how they compare. A good neuropsychologist will also dive deeper and look at cultural norms and take that into consideration too. So when I'm dealing with, like, let's say a Spanish speaking or a native Spanish speaking client, I will almost always send them to not only a Spanish speaking neuropsychologist, but somebody that will take into consideration those cultural norms, because that will put your expert ahead of the game when it comes time to testify as to the information that they've gathered and why it's more accurate than, let's say, somebody that's doing the testing in English and is not comparing that person to their peers and people that are coming from the same background. Actually, you may end up having your client perform better, meaning that they seem less impaired with that person that's actually comparing them to their peers than somebody that's not. Because what will happen is the person that's doing it in English and not comparing that person to somebody that's coming with the same, educational background, or is not a native speaker or not native to whatever the cultural norms that are going to be standardized in the US, they might not get everything. They might not understand all the questions the same way because they're coming from a different background. And so they will get those things wrong, but it will be like a false wrong. So it's helpful for you to be able to use that expert to show that, you know, this data is really objective because I've incorporating those norms in my testing. So back to
Actually, Tina, sorry to
Yes.
interrupt you again. I know that we've been going for quite a while. Ginger, is now a good time to take a break to hear from our sponsors?
Yeah, that would be awesome. If you don't mind, we'll just take one quick break because I want to introduce you guys to Patrick over at OnPoint Legal Nurse Consulting. We are really, really excited to have him join us today. He's also going to be one of our amazing speakers that's joining us in Nashville, May 5th through the 7th for our TBI seminar that we're doing along with pain, suffering, and damages. And by the way, you guys, the agenda has been added to the website. We're launching it, so you can go ahead and register and definitely book your room because it's going to sell out very fast. But if you go to connectionology.com, you can see all the details. Patrick, we are so excited to have you with us. It is an honor. As you guys know, we love working with everybody and your entire company. So we're glad that you're here with us to share a little bit more about what you guys specialize in.
Sure. No, thank you very much, and nice to see you again. I'm looking forward to Nashville. It'll be a lot of fun. I'm looking forward to speaking as well and teaching everyone, coming from the nursing side, kind of how our nurses' minds operate. And thank you, Tina and Jessica. Presentation's fantastic, so I appreciate it. My name is Patrick Stonich. I'm one of the program directors over at OnPoint Legal Nurse Consultants and Expert Witness. We're a full litigation support company, so we help attorneys nationwide, not only behind the scenes with our consult program, but also our expert program, finding experts to match them up with cases that you might be working on. One of the things that makes us a little bit different than everyone else, we do not charge at all for any expert placements or the searching for them. That's part of our program director's responsibilities. So we leave that up to managing the experts to us, and then we present you guys with a couple options, and then hopefully if it works out and everything matches up nicely, we connect you directly. We always have us behind the scenes helping kind of manage the case and move things forward. We also have an admin team that helps keep everything organized, make sure everyone's on time, and that the reports are getting over to the people that need them on time. One of the cool things that, you know, specifically based off of this topic for traumatic brain injuries, we have a group of nurses. I'm one of them, which I've been practicing nursing for 18 years. I do a lot of the pain and suffering reports, which are very important in traumatic brain injury, and also help the attorney clients with doing interviews with the patients. I work with some of my counterparts that are female nurses. I, of course, am a male nurse. Sometimes we have different answers depending on who is doing a patient interview. And I'm sure a lot of the attorneys out there, when they're doing intake and asking questions to their clients, they'll answer questions very differently than how they're going to be answering questions to a nurse and even doctors. So we would love to participate in that intake process. We love to participate when we do our pain and suffering reports and our life care plan reports, to having that interviews with the patients and the families, and making the medicine a little bit more simple to not only understand, but also give that storyline of how the patient is affected by this injury and how it's affecting their lives, both personally, outside of their lives, and kind of everyone else that is involved. And that's one of the wonderful things that nurses are able to do. We're extremely well trusted in the world as part of our industry, and that goes a long way. We know how to ask questions a little bit differently, coming from the, not just the legal side, but not just the medical side from doctors. We're trusted with these answers and the questions that we present. So I'll post my information online. Everyone can reach out to me directly. My program, I work with Ingrid, who's fantastic. She's been a nurse for over 40 years. We run the long-term care geriatric division. So anything that happens in long-term care areas, we manage those. I also work with Lisa, who does our life care plans and some of our chronologies. And Dawn helps us with our expert placement for any of our medical providers and doctors that are kind of any specialty area that we can help with. Looking forward to hopefully seeing some of you in Nashville. And if anyone has any questions, just let me know.
Perfectly said. Thank you so much, Patrick. And
Wow.
I echo everything you just said about everybody you guys work with. Y'all have tons of experience, but you're just such a delight to work with. So I do hope everybody saves your information and asks questions, whether they need you now or later on down the road. Thank you for all that you guys do.
You're very welcome.
All right, we'll see you soon.
See you soon.
Now I'm going to hand it back over to Tina and Jessica.
And you are very popular today, Tina. So you have another question. It was before the break, but I saved it for you, so you can pick back up. But the question is, what are your thoughts of the client keeping a daily journal after the crash so it memorializes the changes they are experiencing due to the TBI?
Sorry about that, I was muted. So I was just going to say, I love that idea. I have had clients that have kept journals and brought those in during intake. And there have been times where I've told clients to start keeping a journal. That can be also very helpful when they go to doctor's appointments, because a lot of times they will show up to a doctor's appointment and forget everything that they have been experiencing and just say like, I'm not well, or I'm just fine, even worse, when really they're not fine at all. So if they're able to write down what they're experiencing on a daily basis, it can be helpful. It's also a good tool in terms of treatment. With headache management, particularly a lot of these more expensive medications, if we want to justify them, in the workers' comp arena, we need to be able to provide a lot of literature or data to justify getting authorization for those meds. But in the PI world as well, it's always helpful for the doctors to be providing that information and documenting their use of these medications and what justifies them. Because as we'll get into a little bit later in the presentation, some of these medications can cost upwards of $1 million+ in terms of being part of your life care plan. And so you want to make sure when you include them that they are warranted and necessary and well documented as to why that doctor took that position in terms of prescribing. So going back to parietal lobe injury. So those are injuries near the top back of the head. You're going to see that word finding difficulty that we talked about. Difficulty in academic skills, or you'll see in the workplace, they say that they're not performing like they were previously. Drawing objects, a lot of times in the initial doctor's appointment with clients that have had TBI, they will have them draw a clock and say, okay, we want you to put the time at 3, and their ability to do that is off. Their brain is not computing things properly in how they draw. Difficulty distinguishing left to right. Sometimes you'll see that with people that are dyslexic. You can also see it with brain injury. And then lack of spatial awareness. That's another thing that also will come into play, because you're seeing a lot of issues with their hand-eye coordination, and their visual acuity also can be affected. And going into occipital lobe injury, the back of the head, a little bit lower. You will see inability to recognize words. So we'll see a lot of times in speech therapy, the patient will be looking at cards with, cat, and not be able to register what that is. You'll see, again, vision issues. Sometimes you'll even encounter hallucinations, color blindness, difficulty locating objects in the environment. So they cannot differentiate sometimes between objects, or sometimes, they are looking at like illustrations and are not able to identify a specific object. Difficulty with reading and writing, kind of this example I gave you before, where the person keeps rereading that same line. Their eye is not following appropriately anymore. Reduced peripheral vision. Again, a lot of times they'll complain during driving, they're having issues. And then temporal lobe injury, so side of the head above the ears. This is another common location of head trauma you'll see, from people that are falling on one side or the other. Difficulty recognizing faces. Sometimes it's very sad, but we'll see clients will say, in the hospital, my kids came in and I didn't recognize them at first. Difficulty understanding spoken words. So when somebody's speaking to them, their brain is not registering exactly what they're hearing the way it once was. You'll see a lot of times interference with memory. So short-term is much more common in my experience. I'll hear a lot of clients that their short-term memory is impacted, but they can remember things from long ago much better, but it can involve both. You'll see issues with decreased interest in sex, lack of libido, inability to characterize objects. And then specifically for the right lobe, you're going to see issues with persistent talking. So that person can't take a clue. They just keep going on and on and on. And you cannot really get that, redirect them to where the conversation was. They'll go off on tangents. It's also, you know, sometimes you'll encounter aggressive behavior, mood disorders. People will come in and, you know, the wives or the husbands will be saying that, you know, he or she is not acting like he once was. He's increasingly short-fused, irritated, and going off about the smallest thing. And then again, the ringing in the ear. And then when you see brainstem damage, which is one of the more rare types of brain injury that we'll encounter, but is still very prevalent, you'll have this dizziness or nausea, the vestibular issues. A lot of times clients will say they have issues navigating stairs, or they have issues where their feet, like they're off balance, you know, so their regular walking is impacted. You'll hear that they've had falls, or they've had issues getting in and out of the bathtub. A lot of clients will say, I'm not feeling dizzy, but then when you say, okay, what about when you get up out of bed? Oh, that's when I kind of feel a little off and I have to center myself. So you want to get into things a little bit more deeply when you're talking about the symptoms again, because sometimes they're not consistent. The symptom can be triggered by something particular. So you want to get into the nitty-gritty when it comes to that. And then again, kind of like difficulty with speech, their capacity in breathing. You will see, again, the brain is very complicated. It affects everything. So there's nothing really that's out of the realm of normal in terms of brain injury. I've seen it all, and you need to, you know, take it all in, document it all, and then have the appropriate specialist take a look and see how it's really related to the brain injury. And then lastly, the base of the skull, again, you'll see a lot of some similar symptoms in terms of, you know, impaired gross and fine motor coordination. You'll see tremors, dizziness. And again, the dizziness can vary and can be weeded out during VNGs, these vestibular evaluations that are able to discern exactly how the brain trauma has caused it and what exactly in terms of the vestibular system is affected. You'll see issues with slurred speech, difficulty or inability to walk, and difficulty controlling their posture or trunk control. And then this just kind of gives you a little bit of a more broken down illustration of what we see in terms of symptoms. So we'll see a lot more complaints in terms of concentration and memory, irritability, headaches. Those are some of the most common ones that you will see. And then it'll go down to the ones that are less common in terms of like sound sensitivity, light sensitivity. I will a lot of times ask clients how they're faring in going out into busy spaces, because that's when they start kind of putting two and two together in terms of figuring out that, oh, there is something that's a little bit off. I didn't realize it at the time, but I just didn't want to be at the mall. It was too much. I felt overstimulated and I didn't really understand why. And, you know, you have to start putting the puzzle pieces together. So just to kind of break it down, you want to figure out the nature of that physical incident. Were they struck in the head, or was it one of those injuries where they might not have had actual trauma to the head, but they had that jostling of the brain within the skull? A loss of consciousness. A lot of times you will have a client that says, I didn't lose consciousness. I didn't black out. But then you ask them to tell you exactly what happened from the time of injury till the time, let's say, that they got home or got medical attention, and there's a gap of time. And then you start realizing, or you start explaining to them, well, don't you think that there's something that you might have passed out or you might not have remembered? Loss of consciousness is not always somebody being like eyes closed, sleeping. It could be just a gap in time where they're not remembering. And that is a loss of consciousness. That's a lot, you know, they're uptunded. There's a lack of awareness of what's going on. Their eyes may be open, but they don't remember. And to me, I characterize that as a loss of consciousness. Also, you will want to be on the lookout for a Glasgow Coma score. Those are out of 15. Usually, if you're seeing a 15 or 14, they're characterizing it as a normal. Depending on what hospital you're seeing, there may be the scale being out of 14 or 15. So it's important, if you are deposing, medical personnel from that hospital or facility, that you are finding out if they're using that 15-point scale or 14, because if it is 15 and they have logged that person at 14, then they may be abnormal. Amnesia. There's a lot of times clients that will not remember even getting up that morning, or they don't remember going to work or getting into that car. You want to find out what their first memory is before the accident, as well as what their first memory is after, because when you are looking at anterograde or retrograde amnesia, those are more severe brain injuries and should be, qualified as such. And then initial neurologic findings. If you're looking at seizure activity or things of that nature, then you're looking at a more severe brain injury, and your workup needs to be situated that way from the beginning. And then initial imaging findings and neurocognitive testing, which we're going to dive deeper into. So once you have identified the case as a potential TBI, you want to get into getting that objective information and diagnosis from a medical professional, obviously.
Hey, Tina, there was another question that came in. It says, is post-traumatic BPPV or benign paroxysmal, probably butchered that, positional vertigo a brain injury, or it can be confused with one?
So it can be a byproduct of brain injury. So when you're dealing with issues with vestibular dysfunction, it can be secondary to the brain injury or is caused by it, and its diagnosis is helpful in confirming brain injury. So getting back into diagnosis, the first place that you're traditionally going to start is with a medical exam. You want to make sure that your client is prepared with the information necessary to provide what the doctor is going to need to make that diagnosis. So what we talked about a little bit, or somebody asked about in terms of having a journal, those are helpful to bring in. Bringing in that checklist that they may have filled out in your office. Those things are going to be really important for the doctor to have in order to put the pieces together and make that initial TBI diagnosis. Also, a lot of times, especially when I notice that the client themselves may be a poor historian, I will ask them to take their spouse with them for that initial appointment, or whoever the person that lives with them, somebody that has a better idea of what's happening in terms of how they've changed since the accident. It can be very helpful for the doctor to have those secondary sources of information. So you get, in terms of doctors that I would send a client to for initial diagnosis, it can happen anywhere from a chiro to pain management to ortho. But if I'm going to specifically send somebody for a TBI workup, I will try to find a physical medicine and rehab doctor that specializes in brain injury. They take a whole body approach to brain injury, a little bit different than you'll typically see with like a neurologist. And those are the ones that are going to be able to particularly, provide that diagnosis in a mild TBI or concussion case, because they're going to look at, those other issues like the vestibular or the bringing in the ears or the vision issues, and document that and help that in painting that picture of this person's having, a post-concussive issue or a brain injury. So once you get them into that initial evaluation, most often a lot of plaintiffs' attorneys will ask me about, what do we do in terms of imaging? So in terms of imaging, the most common imaging that's done, and this is initially in the hospital, is going to be a CT scan. The CT scan is what's really necessary to rule out any significant defects. So if they are having any sort of structural changes in the head or in the brain, or if there's a large bleed that needs immediate medical attention, that CT scan is going to be able to find it right upon having that done, and be able to get that appropriate medical intervention if necessary. But more often than not, the CT scan is going to be unremarkable, clean, and just a tool to show there was impact to the head, even though it's a clean result. They did it to weed out something more serious. But then when you are getting into the point of, coming on as the attorney and want to help to provide objective data of brain injury, a lot of times people will, look to an MRI. And MRI was, up until, the last few years, the most useful tool we had in terms of imaging to provide documentation of brain injury. However, it is often also, something that will have unremarkable results, and it shouldn't be the be all and end all, because just because somebody has no objective findings on an MRI does not mean that there's not a brain injury. I would say probably about 75% of the clients that I take on, they have no positive findings on a CT or a regular MRI, and still, there is a substantial recovery and there is a substantial injury involved. But in terms of, if you do really want to get imaging and it's an MRI is something to consider, I would strongly recommend looking at a DT MRI, so diffuse tensor imaging. It's the most sophisticated type of MRI that we have general access to at this point. They run best if it's a 3 Tesla DTI. And basically it's a quantitative measurement. It's using water's motion within the tissue to help provide an estimate of the amount of damage sustained by the nerves within the brain. So, the disease or injured areas are going to be more diffuse than normal. The reports are generally very, substantial and provide a lot more data and information as to exactly what's going on than a typical MRI would. And it's something that's good to consider early on, and maybe something that is revisited, down the line for a second MRI, because you can sometimes see changes over a period of time that could be helpful to provide documentation, especially when you're looking at a more moderate to severe brain injury. You want to show the progression of that disease process. Another type of MRI another type of imaging that we have been seeing, but is less common, and there's a lot more pushback within the defense community as to the efficacy of it, is the SWI, so susceptibility weighted imaging. It's a sensitive MRI technique that's using, it's there to also detect these microbleeds that would not be necessarily detected with a conventional MRI. At this point in time, I traditionally will lean towards a DT MRI over the alternative, because I think that there is more literature suggesting its efficacy, and I think that there are more providers that are able to, give you that accurate reporting that you need in order to prove up your case, as opposed to some of the other newer imaging that's coming out. Even if it is more precise, sometimes you're going to have more difficulty in court being able to bring it in and bring your expert in using that science.
And maybe you touched on this a little bit, but one of the questions says, is the DTI a different type of scan, i.e. machine, or is it the software?
It's a different type of scan. So you're going to have to go to a facility that specifically does DT MRIs. They're right now becoming more and more available. So it's, especially in bigger cities, you're not going to encounter much difficulty finding a facility that has DT MRI. But it's not something that they can just take a regular MRI machine and be able to do a DT MRI.
And then there is another question. Is it possible for a client's symptoms to come and go, meaning they're fine for a few days and then feel the symptoms again?
I would say absolutely. I think that that's actually more common than not. When you're dealing with brain injury and the person is experiencing symptoms across the board, a lot of things can impact the severity of those injuries, like sleep, nutrition, stress. So, when they have sustained this change in status or this brain injury, and they do everything as perfect as possible, they get a full night's sleep if they can with the proper medical intervention, and they keep their stress levels minimum, and they have family all contributing to try to take care of everything for them. They're eating right. They may have good days, but something's a little bit tweaked. They have a bad night of sleep, and for them, it's so much harder for them to be able to cope with the symptoms that are able to be kept at bay when everything is running well. So I would say it's very common. That's also why it's important for them to really, keep track of what they're experiencing, not just in a 1-day period, but on an extended period of time. And I also tell clients, you don't want to just tell them about the good days, or you don't want to say, my headache today is a 2. If yesterday it was a 7, you're going to want to say it can get bad as a 7, so that the doctor is getting a full view of how bad things can get and is treating you not only for the good days, but for the bad. So another diagnostic tool that we often will see used with mild TBI especially, but it's necessary across the board, is neuropsychological evaluations and assessments. So neuropsychology is a subset of psychology. They are specifically equipped to do testing or cognitive battery of tests that are able to weed out whether you're having any sort of cognitive dysfunction, psychological disruption, things that have changed as a result of your brain injury. And the theory is that they are able to provide you objective data of brain injury, because there are, tests incorporated in that provide there are safety measures in place to allow you to not be able to fake bad. So it's thought that somebody cannot sit down and take that test and, basically perform in a way that's going to make them look impaired when they're really not. So with that said, a good neuropsychologist not only will be able to provide you with information as to what their patient is experiencing, but also will be able to take the medical information and the reporting that's available to them and correlate that to what the data in their testing is showing. So, this person is experiencing a frontal lobe injury and they performed in these areas at a deficit, and that correlates. So, I would recommend, in terms of when to get a neuropsychological evaluation, a lot of times it will be helpful to do it more than once throughout the case, especially ones that are going on for, they're going into litigation and it's going to span over a period of greater than a year. I will try to get one for a client, within the first 6 months post-injury, because typically the medical field feels that somebody that's experiencing symptomology after 6 months following the injury is experiencing post-concussive syndrome. And these are more serious, issues that need to be evaluated in more depth. The reason for that is that there's a lot of medical literature that says that a brain injury will resolve itself within the first 6 months. And if it doesn't, that's when you really need to look at it a little bit more deeply. I don't know if I completely agree with that. I don't think that it needs to be 6 months before you take a closer look. But I would say that generally neuropsychologists will like to wait until the 6-month mark to do their initial assessment. They will also want to look again after the patient has completed some rehabilitation or some therapy. I think that's a valuable tool to show that, they performed a certain way, they did therapy, and they maybe improved in certain realms, because it's showing that, the treatment is working and you're substantiating the need for ongoing therapy, lifelong potentially. So, having those two testing points and showing the difference is a helpful measure to provide when you're making a demand or when you're in litigation. Another area that you can use in terms of, providing data regarding the brain injury is visual acuity testing. So it's not what you typically think of, when you go see an eye doctor and you have that chart and you're just holding one eye. That's not what the visual acuity testing that goes into neurooptometry evaluations. They are looking a little bit further or deeper into your visual acuity, not only to see, issues with peripheral vision, but also, blurry vision. They're having issues with tracking. They're having issues, with comprehending what they're seeing. And those things can be weeded out and documented more in depth by a neurooptometrist. So you may want to have, your primary physician that you've elected make a referral for that, because there's also therapies involved that may be helpful in your workup. With a neurooptometrist, they'll do vision therapy, and that can be extensive and costly and should be accounted for. Then going kind of more in depth in terms of the balance issues that we talked about a little bit earlier, and there were some questions about, there's another objective tool a tool that provides objective evidence of brain injury, and that's a VNG, or a video nystagmography. So a VNG, basically, it is a tool that's used to measure the inner ear central balance function in patients that need diagnosis following, some sort of issues with balance or dizziness, okay? The test measures your eye movements and the responses to inner ear balance stimulation. It's basically a pair of goggles the patient is going to be putting on, or the client's going to be putting on, and they're going to be following a stimulus. The good thing about this test, not only in terms of providing you a tool to get your client treatment, but it's also providing objective evidence of balance dysfunction, and therefore objective evidence of TBI. So you want to get that test if you're having a client that's experiencing any sort of balance issues, dizziness, nausea, things like that. That's going to be something that you're going to have either your the primary doctor that's treating them, or a secondary physician, like a referral to an ENT. Many ENTs are able to have a VNG done in their office or refer the patient out for one. So you get some of the objective data, you're getting the client evaluated, and it's important to know that, the complications associated with not getting them the appropriate treatment, because the longer the patient or the client goes without treatment for brain injury, the longer they're going to potentially have ongoing disability that prevents them from functioning well in home, school, or work. So we've already gone into some of the details. Physically, you're going to have the balance, the hearing, the vision, speech, ambulation, motor control. But cognitively also, you're going to have the memory issues, concentration, things like that. Psychologically, it can have a big impact on the person. Not being able to function as your former self is going to not only affect you psychologically cause depression and anxiety, but you may also have, organic brain injury, psychological issues that are causing behavior problems or causing issues with initiation. You'll have a lot of times clients that are appearing to behave like they have something similar to ADHD. And so it's something that requires intensive treatment potentially to help and develop coping mechanisms that are going to help that person long-term. Just giving you a little bit more information as to what you're going to want to document when you are making a demand in a brain injury case, but also, take into consideration is, there's a lot of long-term complications following TBI, whether it's tendency for re-injury. I have a lot of clients that are having falls secondary to vestibular dysfunction following brain injury, and they become fall risks. They need ongoing or long-term attendant care to help them with that. Again, the psychological impact that presents with brain injury, depression, anxiety, isolation. And then you're also having, it's impacting the whole family, whether it's the stress that taking care of that person is now causing the family, but also, the impact that their behavioral or psychological issues are having on it. So you need to really take a big look at the full picture of how this person's brain injury is affecting them from A to Z and their ability to function in the world. And this is kind of, again, another slide giving us more information on that, the long-term effects. But to go into specialists involved in treatment of TBI, I mentioned a couple of them. Physical medicine and rehab, in my opinion, is probably the most valuable specialty to have on board in terms of treating TBI. I think that they really are considered the quarterbacks of the case and are able to, make appropriate referrals, but also treat the patient from head to toe and weed out all the issues that they are having secondary to a brain injury. When you are dealing with complex headache issues or more severe brain injuries, you're having things with issues with seizures or other serious complications, you may need to bring neurology into the case. I think they are specifically helpful in headache management, and there's a lot of medications out now that are rather costly and need to be, considered when putting together a life care plan for a brain injury survivor. So it's helpful to get them involved as well. Neuropsychologists would be necessary, as we discussed earlier, to get that complete battery of tests necessary to get diagnostic evidence of mild TBI. And then some of the other ones that are not always as necessary, but like psychiatry, especially if you're having a client that, there's reported behavioral issues, they may need medication management. Neuroendocrinology. There are often, associated hormonal imbalances secondary to brain injury that should be looked at more seriously. If you have a client that's saying that they are gaining weight, they are constantly fatigued even after having a full night of sleep, they have lack of sex drive or libido, you should have them evaluated potentially by an endocrinologist or a neuroendocrinologist, because if they are having some form of growth hormone deficiency and they need supplementation, that is potentially $2-3 million worth of medication over their lifetime that needs to be contemplated and incorporated. And it's a game changer in terms of their rehabilitation. Oftentimes the client, when they do get the appropriate medication after seeing an endocrinologist, they say that they are feeling significantly better and able to manage some of the symptoms that they weren't able to deal with before. And then with that said, they work oftentimes hand in hand with urologists, especially when you're dealing with sexual dysfunction secondary to brain injury. And then, as I've said over and over throughout this talk, the brain can affect all parts of the body. So sleep, pain, internal issues secondary to also medication. So you're going to have to bring in multiple specialists often. And I urge client or other attorneys to definitely get all of these specialties involved early on. Not only is it helpful in terms of getting your client the care that they need and treatment that they need, but also you want these specialists all to chime in and provide their perspective on what is needed long-term when putting together a life care plan. Now, another big thing, and this comes into play a lot of times in my workers' comp cases, is multidisciplinary brain injury rehab. These multidisciplinary programs are able to provide, physical therapy, occupational therapy, speech, and they have inpatient and outpatient programs. These programs are incredibly costly. They're from like $30,000, $40,000, $50,000 a month, and sometimes are necessary long-term, depending on the level of dysfunction following brain injury. And they not only are giving your client the treatment that they need to get rehabilitated, but also they give you a wealth of information documenting the deficits that the person is experiencing. So when I'm dealing with more, catastrophic injury, and especially on the personal injury side, when we deal with cases involving commercial policies where there is the funds available to acquire this kind of treatment, I will almost always suggest a brain injury rehab program, because they are like the front line in terms of getting the appropriate treatment for those clients, and then also are giving you the best information as to what the person is experiencing and the best data to use when you are litigating those cases. And some of those therapeutic interventions that are involved in rehab at a brain injury rehab program are what's documented on this slide. So the vision therapy, also vestibular education, aquatic, are in addition to the main therapies which we usually think of in these programs, which is physical therapy, occupational, and speech. Another big thing in terms of treatment for brain injury that I will often, pursue for clients is cognitive behavioral therapy. This can be pursued through a neuropsychologist as well as a regular psychotherapist or psychologist. It is a effective tool that can complement the brain injury rehab process, and also can provide a lot of information as to what that client is dealing with secondary to the brain injury. For clients that are not, the brain injury rehab programs are not accessible because of, location, there are a lot of home and community rehab programs out there. They will actually come to the client's home and do the therapy there, which is a great thing to have available for clients that are in more rural areas, or if your city does not have a brain injury rehab program. And not only do they provide, therapy for the client, but these programs, I think, provide some of the best data to substantiate brain injury. They are also very costly, and they should be incorporated into the case so that they are also part of the life care plan, because it could be something that's needed long-term, or again, throughout that person's lifetime several times over. Brain injury is not like a broken bone. It's not going to just resolve itself, once it's been rehabilitated or it has a cast and go away. It's something that person will potentially deal with lifelong. So you want to make sure that you are getting them treatment not only early on, but accounting for provision of lifelong treatment. So I would definitely consider home and community if the client is not able to access something in a facility close by. So in terms of getting them care, obviously that's the most important, is to get them the treatment they need, because it helps them get better. But we also want to make money for our clients and to get them the appropriate recovery. So what I mean by that is that you need to really, when it comes to brain injury, there is a lot to consider, because everything can be affected. And it's also important to consider, some of the little things that we often don't consider as a big cost driver in our case. Like, for example, with orthopedic injuries, most of the medications available to treat them are not big cost drivers in our life care plan, and are not something that we're really focusing what we're pursuing, like in terms of treatment to build up our case. But with brain injury, it's very different. Some of these medications are actually the biggest cost driver in your case. So for example, when I talked about a client, that I had, for example, he was feeling sluggish, he'd gained weight, he had a loss of libido. We sent him to an endocrinologist. They did a blood test and diagnosed him with growth hormone deficiency. The main medication used to treat it is genotropin. Genotropin, for the standard dose for a patient is costing about $2,000 a month. And over their lifetime of somebody that's like 43 years old is $842,000. So it's important, with a simple blood test, you can identify if they have growth hormone deficiency, and you are able to get them the appropriate care early on. That's, warranted. It's substantiated by lab work. It's something that's very clear cut and cannot be disputed. So I think that there was a question earlier on in the talk regarding, pituitary dysfunction. This is very prevalent in people that have sustained moderate to severe TBI, and you need to have appropriate lab work completed by either an endocrinologist, or often even a primary doctor, like a physical medicine doctor or a pain management can do that initial lab work to discern if there is some sort of impact on the pituitary, and get them the appropriate care or referral to an endocrinologist. So when you have a brain injury, just to give a little bit more information about it, you may experience a partial or total failure of the hypothalamus, the pituitary, or the adrenal glands. So it's going to not only impact sexual functioning, but it's also going to impact their sleep, their energy levels, their ability to metabolize glucose. So you'll also see a very big uptick in the prevalence of diabetes secondary to brain injury, and the care that's associated with that. The medication needs to be incorporated into your life care plan. So if I see a client that's coming in that just recently is diagnosed with diabetes months following a brain injury, I almost always am going to be trying to work up that into my case and make it secondary to the brain injury, because it's usually, it's very odd to see it all of a sudden coming on following a brain injury if it's not connected. So another medication that, can be taken into consideration when you're talking about brain injury is things that are associated with the behavioral disruption. Pseudobulbar affect, for example, is a neurological condition that we often see following brain injury. You're seeing clients that are saying, I am finding myself crying for no reason or laughing for no reason. I don't really understand what's going on. There's a very simple checklist or test that a doctor can give them to identify if they're experiencing this secondary to brain injury. That medication, again, over their lifetime of somebody that's, needing 50 years or 25 years of medication can be several $100,000. So it's good to take it into consideration. Again, these medications are very costly and need to be probably at the forefront of what you're pursuing for a client when you're looking at treatment options for them.
Hey, Tina, this
Yeah.
has been outstanding so far. Would it be okay now? Is no time just to take a few minutes? We'll take a break.
Absolutely.
And then what I'll do is I'm going to bring in Richard from HMR and Nathaniel from Fox AE, and they'll just take a second just to tell everybody some of the great things that they do over there. We're getting tons of amazing questions, so I'm trying to hold them just at the moment so we can kind of get through the rest of this, but it is incredible.
And this is the last slide, so after that we can do questions.
Okay, perfect. Well, I wonder if you want to finish this and then I bring in Richard. Either way. Okay. All right, let's see. I think Richard will be here in just a moment. And then in the meantime, I bring in Nathaniel. And then if you guys have any more questions, now's the time to go ahead and start bringing them in, and we will ask them after she finishes the slide. But I'm so excited. Richard is here with us, you guys. We haven't seen him in a while. He's been out there on the West Coast as well in California. And as you guys know, we are thrilled to have him back with us. He's with HMR, another amazing company that we totally support. So Richard, glad that you're here to share all the great things that you guys do over there at HMR.
Thank you very much for having me. And thank you, Tina, for the excellent presentation. This is my bread and butter. I will say that 80% of my docket is brain injury all around the country. And I think that goes for most of HMR too. So HMR is the most premier funding source in the country for attorneys that need money for either medical costs, if their plaintiffs need money to pay bills, or if the attorneys need money to go to trial and get their plaintiffs justice. So we're kind of the one-stop shop, and we're also always aware of being competitive and also being as ethical as possible in this industry. I've been in this industry for a long time, and I would say that we probably have the best reputation out of most of the companies out there in our industry. So you can rest assured that we're always going to do what's best for you and your client. Brain injury is something that we are very familiar with. We have, been all the way. One of my cases went all the way to Texas Supreme Court, in an injury case, because we're not shy to go all the way. I know some other companies might not have like the capital or the experience to do that, but rest assured that we do. So if you've had any experiences in that in the past, just know that we're a great partner in that. Tina did mention a lot of great points. We have providers. Right now, we operate in 40 states. So don't be afraid. I know it's really scary to have a brain injury, especially the first couple ones. Don't be afraid to reach out to people like me or Ginger or Tina if you have a case, because we're going to give you unsolicited, advice or what our opinions are, or help connect you with the right people. Since we are heavy in litigation, we do know the good experts to go to, because the better your experts, the better your outcome. Sure, they might be pricey, but remember, we have the capital for that as well. So whatever your needs are for these type of cases, don't feel hesitant to try to pursue. And sometimes it's just not your cup of tea. And if you have a case that you're working up or we're working on together, and eventually you decide it's too much to take on, or I don't have, XYZ for this, we know great attorneys to refer those to as well. So since we have such a great reputation, we know the people with great reputations, and that's why we're a part of Connectionology, and because they have a great reputation, and they teach people the honest truth about these type of cases. And the technology is always ever changing, so we're always in the forefront of that. I just signed on a new national brain injury provider. They do neuropsych exams, telehealth across 38 states, if I recall correctly. So there's always providers out there that are getting excited about the cutting edge technology and bringing in new scanning devices, new impressions, like Tina talked about. We have DTI available for our clients, and many other modalities to help prove your damages, show that your client's actually injured. One thing, I know if this was mentioned before, but brain sharing, that's a big problem. And after a year, sometimes people think, oh, I'm fine, I'm getting better, whatnot. But after a year, their symptoms come back and even worse. And it's a form of injury called brain sharing. And those type of injuries were not known. I mean, shucks, 5 to 7 years ago, it was very hard to quantify those damages. And now we have the technology to do that. So if you have any questions, please don't hesitate to reach out to me or any of my colleagues. I will leave my contact information in the chat. And and consultation's free, so don't be scared to pick up the phone and call. Thank you, Ginger. Thank you, Tina. Appreciate y'all.
You are very welcome, Richard. Thank you so much for coming by. Please come back more often, okay? Because it's been way too long.
It has been. Thank you
And
so much.
we hope we'll see you on the road somewhere soon, okay?
I hope so too. I miss y'all. Thank you very much.
You too. All right, and now our dear friend Nathaniel is with us with Fox AE. He is covering for Cody today, and we are so glad to have him. He's actually a new father as well, so congratulations, Nathaniel.
Yeah,
And
thank you.
thank you so much for taking a moment to just come in and say hello to everybody and tell us a little bit more about what you guys do.
Yeah. Again, thanks for having me here. And would I be able to get screen sharing capabilities? I think I might stop sharing. But yeah, my name is Nathaniel Murray. I'm the VP of Operations / Project Manager here at Fox. We basically just do pretty much any graphics you need. We can do for you. If we got still shots you need animations, we can do that. So here I'm going to go ahead and play you a brain injury animation that we did recently. And our brain demonstrative has actually, we've been part of a record-breaking case in Arizona quite recently. So in this particular case, this was a carbon monoxide poisoning case, and we show all the different vessels and stuff in the brain to show the damages. I don't know if you saw it fade to a darker color to illustrate the damages, but we go through each different parts of the brain and we show the nasty discoloration on the brain, which may or may not be medically accurate the way it looks, but it definitely illustrates how the damage in the brain. We also show cross-sectional cuts that you can't really see on the exterior view of the brain. And then we zoom into all that nasty damages in there. So that's a little bit of an example of what we do. Again, we don't just do medical stuff, brain stuff. We do accident recon, we do construction, animations. We even can take your presentation, turn it into something amazing, add some of our illustrations to make your presentation that little bit better. So if you have any questions, feel free to shoot me a message, and I'll paste my information in the chat as well.
Awesome. Thank you so much, Nathaniel. And I tell you what, we've seen a lot of your work. That's just a tiny snippet, like I said, of what you guys can do. I've seen some incredible images and animations that you guys have come up with. So thank you so much for being with us. Thanks for being here, and tell Cody that we said hi. I'm sure he'll be back again very soon. And be sure to put your information in the chat box for everybody, okay?
Yep, will do. Thanks you.
Thanks again.
Yep, bye.
All right, Tina, would you like to go ahead and we'll get back to that last slide that you're working on, and then
Sure.
we'll get to some of the questions.
Sure,
And thank you again so much. Like I said, you should see everything that's been pouring in behind the scenes. It's all good.
Okay, so just to wrap it up, with respect to what I do personally in our office, we do a lot of crossover cases involving workers' comp and personal injury. This may be more specific to California, and in other states, the nuances may be a little bit different. But when we have a crossover case, a lot of times it's important to really care about, the workers' comp counterpart of the personal injury attorney, because we have a system called utilization review that's involved in all of the treatment that you get through workers' comp, where the insurance company is using a set of, peer-reviewed guidelines to substantiate authorizing care. So when you get medical treatment authorized through workers' comp in California, it's been rubber stamped by the defendant. They've said that this is reasonable and necessary. And that's going to really be instrumental in working up or proving up damages in your third party case, because you're going to be able to show that this treatment was actually reviewed by another defendant in the workers' comp matter and rubber stamped as reasonable and necessary treatment. This is not something that you're going to be able to dispute. And in addition to that, a lot of the treatment can be paid for and funneled through the workers' comp case. So when you're having a case that involves, issues with liability, where you may not be able to necessarily, do everything that you would want for that client through funding, you may be in a position to do so in a crossover case where you wouldn't ordinarily. So I would strongly urge personal injury attorneys to work well with their workers' comp counterparts and try to collaborate with them when it comes to treatment, because you may be able to build up a case in a way that you wouldn't be able to necessarily if there wasn't that workers' comp component. So that's my presentation today. Thank you all for joining us. Thank you, Ginger, so much for having me. And I know that you said there's a couple other questions I'm happy to answer.
Okay, fantastic. All right, let's see. Actually, there's a lot of great questions. So we'll get through as many as we can until you say we've got to hop off. But because what we can do, you guys, is we are recording this webinar. I'm going to put it on the Connectionology YouTube channel later today. And then you can always reach out to Tina afterward too. But yeah, let's go ahead and get a couple of these answered, Tina. This one is about, have you heard of a Q test done in conjunction with a DTI? If so, what is it and is it accepted?
So the quantitative analysis, it is a lot of times it'll be done with a DT MRI. It's just an additional information that's being provided or data that's being provided. In terms of the details of it or explanation of it, I would not want to represent myself as a radiologist that could give you the most accurate information, but I would say that it is generally accepted where DTI is accepted. And it's definitely a useful tool and measure to provide diagnostic information regarding brain injury.
Okay, perfect. And then what is your feeling on the controversy between those lawyers who believe you should never present a neuropsychologist at trial or even recommend for treatment and only a neurologist should treat and testify?
I think that it's an understandable concern. Actually, my colleague at the office, Brian Beecher, rarely likes to use a neuropsychologist. I'm in the other camp that likes to use them in my cases. I think that, you have to feel confident in your expert. You have to feel confident in, your client and the injury that they have, and that this information is not going to be, easily refuted by the defense expert, and feel confident in your skills to be able to cross-examine the defense expert. And, if you don't feel comfortable with the medicine, you may want to be a little bit more, careful about pursuing neuropsychology, because it does get really complicated, and, it's not as cut and dry as diagnostic imaging in terms of providing objective evidence of brain injury. So, you have to take that into consideration.
Okay, perfect. Thank you. And then do you recommend an MMPI to filter out malingering or faking bad on performance in addition to the neuropsychological or memory testing?
So a neuropsychologist will often use the MMPI as part of their battery of tests. I would, recommend deferring to the neuropsychologist as to what tests they want to do. And they will most often have their own sets of tests that they like to use and feel most comfortable testifying about. So I'm all for it. I've used it many times, and many of the neuropsychologists I work with, or most of them that I work with, do use the MMPI.
Okay, perfect. And then you may have already answered this one, but Are you familiar with the NeuroQuant scan?
Yes, that was the one we were just
That was the
talking.
one? Okay, that's what I thought. And then if an MRI with a DTI shows brain damage, do you still need to do any other testing to know for certain the client has a TBI?
So in terms of knowing for certain, I think the more information that you have to substantiate brain injury, the better. But I also don't think that you need to look for something to refute it if you have good evidence. So if you have positive imaging that shows up, that finds brain injury or identifies brain injury on your scan, as long as you are pursuing other information that you feel confident is going to support that, then go for it. But don't, say, okay, well, this is not, let me go get another MRI or something like that. It's not necessary. It's a good, generally accepted diagnostic imaging that I would feel comfortable moving forward with in my case. And that's in California. I know that it's an area of medicine that's, has been around for a long time, or a type of scan that's been around for a long time, but there are still, some states that the defense is trying to keep that, expert that's going to testify regarding it out. So, you have to also look at your local courts and see how they are deciding on this type of science.
Okay, perfect. And then I got another more like a comment from Caesar Belli, Caesar High. He asked, when are we going to do an event on the West Coast or maybe even Las Vegas? And that is a great question that I will ask John Romano. I know this year we've got Nashville coming up in May. John's also trying to add another Hawaii seminar at the end of May. And we're going to be doing our Texas deposition seminar in November, which is going to be amazing again. So right now I do have information on Nashville and Texas up on our website, but Hawaii is to come, but we do need to come out to California. And then the other questions, Tina, are just, they'd like to get a copy of the slides. So again, highly recommend to email Tina at the email on the screen right now. I'm also going to email you guys a copy of her contact information, as well as all of our amazing partners that you heard from today in a few minutes after the webinar. And then another question came in about who would you recommend as far as an expert on TBI? But again, reach out to Tina. I'm sure she's got some great suggestions that she could send to you guys. And then I've just got a ton of comments telling me that you guys did an amazing presentation today, Tina.
Thank you so much. Thank you for having me, and
cannot thank you guys enough. Thank you guys so much for watching. Tina, is there anything else you'd like to say before we hop off?
No, just thank you so much for having me. It was a pleasure.
Okay, perfect. And then real quick, I got one last thing I'm going to do, because we can never end a webinar until we do our coffee giveaway. And I've got Ted coming in from HMR, because one lucky winner is going to win 4 bags of the fresh roasted coffee. And Ted will be here in a moment. But Tina, this is something we do on every webinar. I think we've done close to 350 different webinars since April 2020. And Ted has been giving away coffee on every single one.
Love that.
Ted, it's great to have you with us today. Thanks for all that you guys do at HMR. We are all in suspense, so tell me, who is the winner today? We got to know.
I have a visitor apparently somewhere. It's one of our many cats on the farm. I'm excited to announce it's Lino Ochawa out of McAllen, Texas is our winner today. So congratulations on some fantastic coffee.
Awesome. Congratulations, Lino. All right, Ted, you know what that means. Both you and I will reach out to Lino after the webinar and make sure that they get this great coffee. Thank you guys so much for supporting us. And don't forget that if you didn't win today, there's always going to be a chance on the next webinar. We've even had some people who've won like twice, right, Ted?
Yep, we've had a few, double winners, yep.
Awesome. And then just as a reminder, guys, I'm going to email you the contact information for all of our incredible speakers and partners, and you guys will be able to stay in touch. Highly recommend to reach out to Tina. Stay in touch with her and continue asking questions, connecting. And again, thank you guys so much for being with us today. Tina, you were amazing, and I cannot wait to have you back. I know you'd be with us in Nashville, but you're going to be getting prepared for your wedding, and we're very excited for that for you. So congratulations.
Thanks so much.
And thank you guys again so much for watching. We'll see you back here again very soon. Okay. Bye, everybody. And thanks again, Ted.